Hello, this is John Kanellopoulos from Athens, Greece, LaserVision Institute, and clinical professor of ophthalmology at NYU Medical School in New York City, New York. This is an extreme keratoconus case. You can see the fleishering, the apical scarring, pre-hydrops picture. On Pentacam maps, you can see that this eye is worsened over the last year. Left eye seen here is much better, almost no keratoconus. The right eye shows extreme keratoconus. On OCT sections here you can see the buckling of the cornea and the stretching of decimates. Keratometry here on that eye, 70.2 steepest K, 73.2 we see here at the peak of the comb. So decision is made not to proceed with DALC, but to perform a penetrating keratoplasty. This is the mushroom femto-assisted program on the FS200 femtosecond laser. Part of the refractive suite by Wavelight Alcon. We're applanating the patient's cornea. You can see the profile of the trephination with the femtosecond laser in the top right of your picture. And once we center the trephination onto the pupillary center, we will go ahead and perform the trephination of this cornea. You will see it starts from the endothelial side up, so there's gas in the anterior chamber, then incises, scores the decimates membrane, goes into the posterior stroma. Then it will create the step that you can see in the top right treatment plan, and then come and surface just short of the epithelial layer. So the trephination of the donor is, the host rather, is completed. We're going now on the donor, and we're using the Catina disposable artificial chamber. The donor cornea is fixated on the artificial chamber, and you can see now the donor trephination, seen in the top right, starts again in the endothelial side up. So some gas in the artificial anterior chamber, the step of the mushroom approach, all the way up to the epithelial layer. We're going all the way through on the trephination of the donor, and soon the trephination is completed. It's remarkable, the trephinations both on the host and the donor are reproduced real time in this video, and it's admirable that by picking with a 0.12 forceps we just have a very clean trephination of this mushroom assisted trephination. Back to the host, the 8 radial marks, viscoelastic in the anterior chamber. We had given pilocarpine to attain meiosis. We're filling the anterior chamber, and here again we're going to peel off the perfectly tree-fine cornea. We have the femto in our operating suite, methicellulose gel again to fill the chamber. And we will bring in the donor button created as you saw before to place it onto the cornea defect and start our very careful suturing here. We need to suture as deep as possible and accommodate the step both on the donor and the host. This is the first or 12 o'clock suture, probably the most important suture of any keratoplasty, the second 6 o'clock suture here, as we're splitting the cornea into 2 halves, and again just to illustrate the point of going with our CS needle and 10 nylon suture deep into the endothelial layer and trying to reach that same layer on the host here, going to get a reasonable bite, and then square knots and bury the knots of these initial 8 interrupted sutures. Very important part here for beginners in keratoplasty to have an equal distribution of the strength when we pull down the suture and tie this knot in the middle. I just picked this particular suture as a indicative of the pressure needed to be put in. Again, a manual surgical technique even in today's date with femto-assisted surgeries. Here, one of the last sutures, probably one of the most difficult sutures for right-handed surgeons, the 5 o'clock suture. Again, same concept here. We're trying to go as deep on the donor through over actually the endothelial side, and do the same in the host. and last suture of this series of 16 interrupted sutures. With the mushroom approach, which I found favorable for keratoconic eyes, as we're transplanting large cornea surface with the least endothelial layer. You can use 8 interrupted with 16 running in my practice, or the 16 interrupted here, but the graft can probably hold with just 8 interrupted sutures. Here, some cellulose patient a few months later. You can see the pristine graft, and we're going to take a closer look soon how the actual graft-host interface looks, and trying to appreciate the beauty of the mushroom and the step that is being created here. Some cross sections of the graft-host interface where we can actually appreciate that step between donor and host, enlarging significantly the interface of transplant and host. Again, different shots, and we're going to go to OCT imaging to get a better view of what I'm trying to show here on the slit lamp. Here we're seeing the epithelial remodeling 2 months out, good thickness, and here you can see a suture track with a suture and the step of the graft-host interface. I'll show you one more of these that were eloquently, as you can see here, caught by my staff. Again, the step graft-host interface. This is still early in the transplantation procedure. Again, another section where the step between graft and host is very nicely delineated. When sutures are out and a year out, this graft-host interface will be maximal and the best possible. So thank you for watching this brief presentation of femto laser-assisted penetrating keratoplasty. This is John Canalopoulos signing out.